everyone, this is Dr. Govind Rai Garg. In this video, we will talk about Parkinsonism. So as we all know, Parkinsonism is an age-related disease, neurodegenerative disease. In elderly people, the patient may develop the symptoms of Parkinsonism. So what happens in Parkinsonism? There are characteristic triad. There is bradykinesia. Bradykinesia means slowness of movement. Person will do everything slowly like heroes do. Then there will be second thing tremors, and third there will be rigidity. So bradykinesia, tremors and rigidity, these are symptoms of Parkinsonism. And we all know the basic problem in Parkinsonism is there is a deficiency of dopaminergic activity in basal ganglia of brain. This we all know. But you need to understand that in the normal person's brain, in the basal ganglia of a normal person, there is balanced activity of not only dopamine but also acetylcholine. So in a normal person, there is balance between activity of dopamine and acetylcholine. Suppose we have 100 dopaminergic neurons working, so we have 100 cholinergic neurons also working. They have opposite function. They need to balance each other. In Parkinsonism, there is a degeneration of dopaminergic neurons. So dopaminergic neurons die, and we assume, suppose instead of 100, now only 50 dopaminergic neurons remain. So only 50 is working now. But acetylcholine is already 100. So this imbalance occurs. So all the symptoms in Parkinsonism, they occur because of this imbalance between dopamine and acetylcholine. So for treatment of Parkinsonism, we have to restore the balance. Remember, this is a normal person's brain. Dopamine and acetylcholine are balanced. In Parkinsonism, dopamine is low, imbalance. So if we want to restore this balance, we have two options. One, we can increase dopamine back to normal. Balance will be restored. If this is not possible, then we can decrease acetylcholine. Again, balance will be restored. So we have two options. One, we can give dopaminergic drugs, which will increase dopamine activity. And if this is not possible, then we can decrease cholinergic activity. That means we can decrease acetylcholine. Clear? So two type of drugs are used in Parkinsonism: dopaminergic and anticholinergic. We will discuss these one by one, starting from dopaminergic drugs. Okay, drugs increasing dopaminergic activity. The first group. To know about these drugs, first we need to understand how dopamine is produced and how it works. Then we can easily know about the drugs increasing dopaminergic activity. So like all the neurotransmitters, dopamine is produced and stored in the vesicles. And how dopamine is produced? First of all, tyrosine comes from outside. There is an amino acid called tyrosine. It comes from outside. This tyrosine is converted to dopa. The enzyme is tyrosine hydroxylase. This dopa is converted to dopamine. The enzyme is dopa decarboxylase. This dopamine goes inside the vesicle and it is stored there. Okay. Now, whenever the nerve impulse comes, this dopamine is released. And now it works on the receptors which are available in the brain. Mostly they are D2 receptors. So dopamine stimulates the receptors and the action comes. But we know that no substance keep on working forever. After some time we have to stop the action, and the action of dopamine is stopped by metabolism. Two main enzymes which break dopamine, these are monoamine oxidase and catechol orthomethyl transferase, MAO and COMT. These are the two enzymes which break dopamine. Clear? So tyrosine comes, forms dopa. Dopa will form dopamine. Dopamine is stored in the vesicle. When nerve impulse comes, dopamine is released. It will produce the function, and then it is broken down by MAO or COMT. Clear? In Parkinsonism, what do we want? We want to increase dopamine or decrease dopamine? Obviously increase dopamine. But at which place we want to increase dopamine? In the synapse, because this dopamine will work. So the question is how to increase this dopamine. The first and the most logical thing will be to give dopamine from outside. We can give dopamine from outside. But it will not work. Why? Because dopamine cannot cross the blood-brain barrier. So we cannot use dopamine. So instead of using dopamine, we start using levodopa. We can use levodopa. It will form dopamine in the brain, and that will treat Parkinsonism. So we can give precursor of dopamine. Second thing we can do is we can give a drug which help in release dopamine. The dopamine which is stored in the vesicle, if it start coming down, it will produce action, and we want action. So we can give a drug which release dopamine. Then we can inhibit the metabolism. So if dopamine is not broken, its level will increase. It can treat Parkinsonism. So we can give MAO or COMT inhibitors. And lastly, what we can do is we can give a drug which directly act on dopamine receptors. So no need of dopamine. The drug itself will start stimulating the receptor, and it will do the function of dopamine. Okay? So dopamine agonists we can give. So 4 type of drugs which can increase dopaminergic activity. They can be levodopa, they can be drug releasing dopamine, they can be drug inhibiting metabolism, and they can be dopamine receptor agonists, the drug which directly work on dopamine receptors. So we will discuss these one by one. Okay, starting with the most important drug, levodopa. So this is our brain. We know brain is bounded all around by a blood-brain barrier. So this is blood-brain barrier. So we want dopamine here in the brain. The problem is, when we give dopamine from outside, dopamine cannot cross the blood-brain barrier. Dopamine cannot go beyond this. So even if we give dopamine intravenously from outside, it will not enter the brain. So dopamine we cannot use. So instead of using dopamine, we use levodopa. Levodopa has the property to cross the blood-brain barrier. Levodopa can cross the blood-brain barrier, enter the brain, and in the brain it is converted to dopamine, and that will treat Parkinsonism. So this is just like a prodrug. So levodopa is a prodrug. It itself is inactive, but it is converted to dopamine to produce the action. The problem is the enzyme which converted levodopa to dopamine is dopa decarboxylase. The enzyme is dopa decarboxylase. The problem is this enzyme is also present in the periphery, outside the brain. So that means when we give levodopa, some of the levodopa can be converted to dopamine by dopa decarboxylase here also. And whatever dopamine is produced here, that is a waste because it cannot enter the brain. So when we give only levodopa, the first problem is it can be converted to dopamine outside the blood-brain barrier, and whichever dopamine is produced outside, that will not be able to produce function. So efficacy will be very low. And the major problem is this dopa decarboxylase which is present outside the brain is very, very active. So if we give 100 molecules of levodopa, only 1 or 2 molecules can enter the brain. Around 98-99 molecules are metabolized in the periphery itself to form dopamine. So what will be the problem? This dopamine 98% cannot enter the brain, so there will be wastage. So efficacy will be very less. Second problem, the dopamine which is produced outside the blood-brain barrier, which is produced outside the brain, it cannot enter the brain. It is a waste, but it will start acting outside the blood-brain barrier. And if you remember, dopamine act on 3 main receptors. It is a D1, beta 1 and alpha 1. So dopamine will start stimulating these receptors. By stimulating D1 receptors, it can cause vasodilation, which can lead to hypotension. So it can cause hypotension. By stimulating beta 1, it will increase the heart rate. Tachycardias can happen, arrhythmias can happen. And by stimulating alpha 1, it can cause vasoconstriction, which can even lead to hypertension. So it can act on the receptor outside the brain. Second thing, this dopamine cannot cross the blood-brain barrier, but it can reach those areas of the brain where blood-brain barrier is absent. Remember those areas are called? Yes, circumventricular organs. So dopamine can enter the circumventricular organs. And one of the important circumventricular organ is CTZ. So dopamine can stimulate the receptors in the CTZ, and that can result in vomiting. So vomiting can occur. So when we give levodopa alone, we have two problems. One, very less levodopa will able to enter the brain because most of it is converted to dopamine outside the blood-brain barrier that cannot enter the brain. So efficacy is very low. Second, the dopamine which is produced outside the brain, it will produce side effects like tachycardia, hypotension or hypertension and vomiting. Clear? So what is the solution to this problem? The solution is, if we inhibit this enzyme, dopa decarboxylase outside the blood-brain barrier, then levodopa will not be able to form dopamine here. So most of the levodopa will start entering the brain, efficacy will increase. And second, because dopamine is not produced outside the brain, so all these side effects we can avoid. Then what is the problem? The problem is the dopa decarboxylase present here and here in the brain are same. So if we give a drug and that inhibit dopa decarboxylase in the brain also, although levodopa can enter the brain, but it will not be able to form dopamine. So when it is not forming dopamine in the brain, then it will be useless. So what is the solution now? The solution is, we want to give such a dopa decarboxylase inhibitor which cannot enter the brain. If it do not enter the brain, then in the brain dopamine will keep on forming. Only formation of dopamine outside the brain will be stopped. So such a peripheral dopa decarboxylase inhibitor is carbidopa. Another drug which is peripheral dopa decarboxylase inhibitor is bensirazide. So whenever we give levodopa, it is always given in combination with either carbidopa or bensirazide. So what will be the advantage of these drugs? They will inhibit the peripheral dopa decarboxylase. So levodopa more will enter the brain because dopamine is not formed outside the brain. And second, this levodopa is forming less dopamine outside the brain. So peripheral side effects, all the side effects which we discussed so far, that means vomiting, hypotension, tachycardia, hypertension, all these can be reduced. Okay, but there is one problem. The problem is, there is this dopa decarboxylase, it contains vitamin B6 or pyridoxine as a cofactor. Vitamin B6 or pyridoxine is a cofactor for dopa decarboxylase. The problem is, it is a common practice to give B complex, or we can simply say vitamins, to almost all the people who come to the hospital. So a patient is of Parkinsonism and we have started him on levodopa therapy, and this person is given vitamin B6, or we can say vitamin B complex, which contain obviously pyridoxine, vitamin B6. What will happen? So vitamin B6, is a cofactor of dopa decarboxylase, so dopa decarboxylase action will increase. So when dopa decarboxylase action increase, peripheral dopamine will increase. So when peripheral dopamine increase, efficacy will decrease because levodopa less will be able to enter the brain, and plus more risk of peripheral side effects. So it is important that vitamin B complex should not be given to patients taking levodopa therapy. Okay, although practically this will not be of that much clinical significance because we always give levodopa with carbidopa. So whenever we have inhibited the enzyme dopa decarboxylase, the cofactor will not be able to do much in that case. Nevertheless, we should avoid. Okay, this is one thing. Now second thing, we discussed there is a imbalance between dopamine and acetylcholine, and what we are trying to do, we are trying to increase dopamine in the brain to balance it out. But suppose we become sentimental someday, jajbati ho gaye ek din, and we give more levodopa than required. So what will happen? This was the situation earlier. We have started giving levodopa and we have given more than required. So what happens? Opposite imbalance occurs. Now dopamine is more in the brain, acetylcholine is less in the brain. Opposite imbalance, and this opposite imbalance lead to psychosis. So excessive dopamine in the brain result in psychosis. So whenever we increase dopamine in the brain, it lead to psychosis. Remember, psychosis and Parkinsonism are diametrically opposite diseases. In psychosis, there is excessive dopamine in the brain. In Parkinsonism, there is less dopamine in the brain. So whenever we want to treat psychosis, what we will do? We will give dopamine blockers. We want to decrease dopamine. So, but if we decrease dopamine more than required, It can cause Parkinsonism. So all antipsychotic drugs can cause Parkinsonism, and all anti-Parkinsonian drugs can cause psychosis. So levodopa can cause psychosis, and this psychosis can manifest as abnormal behavior. You know, psychotic people may have abnormal behavior, like they may develop hallucinations, delusions, etc. And it can also lead to abnormal movements called as dyskinesia. Abnormal movements like dyskinesia. So abnormal behavior and dyskinesias are manifestations of levodopa induced psychosis or any psychotic symptoms. So this psychosis occurs because the dopamine which is produced here increases. If dopamine is more than required here, it can cause psychotic symptoms. Now come to very important MCQ. The question asked is, when we add carbidopa to levodopa therapy, it can reduce all the side effects of levodopa except. If you see what carbidopa do, carbidopa inhibit peripheral conversion. That means it will decrease dopamine formed outside the brain. So whatever side effect is caused by this dopamine will be reduced. So carbidopa can decrease vomiting, hypotension, tachycardia, hypertension, everything can be reduced. But when we give carbidopa, more levodopa enter the brain, so more dopamine will be produced in the brain. So this side effect, this dopamine, with whatever it is side effect it is causing, that will actually accentuate, that will actually aggravate. And what is the side effect of more dopamine in the brain? Yes, these are psychotic side effects. So psychotic side effects like abnormal behavior or dyskinesia, they will be increased by carbidopa. So very important MCQ, which adverse effect of levodopa cannot be reduced by carbidopa? The answer will be psychotic side effects. So the answer can be abnormal behavior, it can be dyskinesia. So basically central side effects cannot be reduced. Okay, then moving to last thing, that is on-off phenomena. Now before going to on-off phenomenon, we will try to understand something. Suppose these are dopaminergic neurons in the brain. Dopaminergic neurons are present in the brain. Suppose a normal person, it contains 100 dopaminergic neurons. Hypothetically assuming it contains 100 dopaminergic neurons. Okay. And in Parkinsonism, this has been reduced and now only 50 neurons are there. 50 neurons are there. Okay. So dopamine become deficient. Symptoms of Parkinsonism can occur. So we give levodopa to treat. Okay. The problem is levodopa will form dopamine. But this dopamine, do you know how long dopamine works? This dopamine will work for 2 to 3 hours. So how frequently you should give levodopa for treatment of Parkinsonism? Obviously we need to give 8 to 12 times. But we give levodopa only once a day. So we give once a day, still all the symptoms are controlled throughout 24 hours. The question is, when dopamine is working only for 2-3 hours, then how it can control the symptoms for 24 hours? The simple reason is storage. We give levodopa, it will form dopamine, and that dopamine will be stored in the neurons. Dopamine is stored in the neurons. Dopamine is stored. So what happens? First, these neurons fire. They will release dopamine, that will work for 2-3 hours. After 2-3 hours, these neurons fire. Then they will release dopamine, again work for 2-3 hours. Then these neurons fire. They will again release dopamine, again 2 to 3 hours. So in this manner, throughout 24 hours, we can do the work. So we give only once a day, and 24 hours there will be no symptoms. Clear? This is the analogous thing, just like household example you can see. We use water daily. So what we do? Is MCD providing the water 24 hours a day? Obviously not. So what we do? We will store it in the tank. So in the overhead tank we store the water, and whenever required we can utilize. So same thing is happening here. We give levodopa, it forms dopamine, and that is stored. Whenever required they can be utilized. The problem is, when we give any drugs for Parkinsonism like levodopa, they are only treating the symptoms, but they are not addressing the basic problem. The basic problem is degeneration of neurons. Neurons are dying. In this example, we have discussed out of 100, normal 100, but in this 50 have already died, only 50 remains. But this progress will continue. Person has no symptoms because we are giving levodopa. But the neuronal degeneration continues. From 50, the neurons will become 40, then they will become 30. Okay? Suppose the neurons die in such a manner, the enough storage capacity is not there. Like normally we require 1000 liter of water in a day. So we have 1000 liter tank. We have initially 2000 liter tank. Even if it fills up to 1000 liter, it is okay. But when the capacity of tank become less than 1000, suppose now we have only 900 liter tank. So what will happen? So we fill the tank in the morning, 900 liter tank is full, but we require 1000 liter in one day. So what will happen? So till night we can utilize it, but almost at the end of the day the water will finish. So rest of the time we have to remain without water. So this also happens in Parkinsonism. When some of the extra neurons die, we give levodopa, then levodopa will keep on improving these symptoms. So there will be negligible symptoms almost till night. But in the last 2-3 hours, the person will start having symptoms. These are called wearing off effect. Wearing off. The effect is wearing off. At the end, it is wearing off. And this will keep on increasing. Initially, the person is having symptoms only for 1-2 hours when we give levodopa once. But when we continue this neuronal degeneration continue, now the person start to have effect for 2-3 hours. Then the person will having effect for 4 hours, then 5 hours. So this will keep on increasing. And in late Parkinsonism, on-off phenomenon occurs. On-off phenomenon means when we give, there is no storage capacity, there is no tank in the house. When we give levodopa now, levodopa will form dopamine, and that will work for how much time? Only 2-3 hours. So rest of the 22 hours there will be full symptoms of Parkinsonism. That is called on-off phenomenon. On means drug is working, off means drug is not working. So this occurs in late Parkinsonism. When we give levodopa, it works for only 2 hours, and rest of the 22 hours there will be no full symptoms of Parkinsonism. Levodopa do not work because it is not stored. Clear? So which is good? On is good or off is good? Very good. Nothing is good. Both are bad. The reason is, we can take the example of the water tank. In the morning the water has come and we allow all the water to come. So what will happen? The flood will occur. We cannot utilize that much water. Remember, normally the 1000 liter is stored in the tank and we are utilizing it little by little by little. So here also the same problem. If we give levodopa in late Parkinsonism, all the dopamine will be released immediately. It will work for 2-3 hours, and 2-3 hours we have 10 times higher dopamine. So what will happen? Yes, psychosis will occur. So on means drug is working, but it is overworking. So for 2-3 hours person will have symptoms of psychosis, person will be violent, person will have hallucinations, all symptoms of Parkinsonism will be there. But after 2-3 hours there will be symptoms of Parkinsonism, because now dopamine is not there. So in on-off phenomenon, person is never good. Either the person dopamine is overworking, person is psychotic, or the person is having symptoms of Parkinsonism. Clear? So what is the solution? Suppose we do not have tank at the home, we cannot store water. So what we can do? We cannot allow all the water to come together because flood will occur. Then what we will do? Every 2-3 hours we will bring a bucket and utilize the water. So same thing is here. So when Parkinsonism develop, on-off phenomenon develop in the Parkinsonism patient, we cannot give levodopa, light dose. So what we do? We give levodopa in multiple small doses. We will divide the dose into multiple small parts. We give 8, 9, 10 times a day. But if some person says that you have to live in a house and you have to bring water every 2 hours, a bucket of water should be brought and then you can utilize it. So obviously that is not a practical solution. So now it is the time to say bye-bye to levodopa. So levodopa should not be used in such a case. We have to use some longer acting drug in this case. Okay. So that is all important points regarding the first drug which increase dopaminergic activity, that is levodopa. Okay. So we have given levodopa. Then second thing we can do is we can give a drug which release dopamine. The dopamine which is stored in the vesicle, if it comes down, it will start producing the effect. And the drug which release dopamine is amantadine. Amantadine is a drug which acts by releasing dopamine. It will release dopamine, it will work, that will produce the effect. But special thing to remember, amantadine is also used for influenza A virus. Actually, that is the main use of amantadine, influenza A, and it has been found to benefit the Parkinsonism patient also. So now it is used in Parkinsonism. So if the question is asked which antiviral drug is used in Parkinsonism, the answer will be amantadine. Okay. Two major adverse effects of amantadine to remember. One, ankle edema. Second, livedo reticularis. Ankle edema and livedo reticularis. Many people who are on amantadine therapy, they may develop ankle edema. There will be plenty of edema on the ankles. It seems like the person had developed CHF. But when we stop amantadine, it will clear. So that means it causes reversible ankle edema. Second, it can cause pigmentation. Pigmentation on the skin in the form of meshwork. Meshwork, pinkish pigmentation on the skin in the form of meshwork, that is called as livedo reticularis. So amantadine can result in livedo reticularis. But special point to remember, unlike other anti-Parkinsonian drugs, amantadine do not cause dyskinesia. If you remember, we discussed earlier, all anti-Parkinsonian drugs can cause psychosis. Dyskinesia can occur. But amantadine do not cause dyskinesia. Rather, amantadine is now approved to treat dyskinesia. This is the only anti-Parkinsonian drug which can improve dyskinesia. The question is why? It is also anti-Parkinsonian, so it should also cause dyskinesia. But how do it improve dyskinesia? The reason has been found that it has additional property to block NMDA receptors. It has additional action to antagonize NMDA receptor. Because of NMDA antagonistic property, it is used for treatment of dyskinesia. Remember, other anti-Parkinsonian drugs cause dyskinesia. Amantadine treat dyskinesia. And from the name you can remember, the amantadine name contains NMDA. NMDA. The name contains NMDA and ANT antagonist, you can say. And ANT antagonist, you can say. So it is NMDA antagonist, additional property for which it is used to treat dyskinesia. Okay. So this was the second drug which can increase dopaminergic activity. Then number 3, we can inhibit the metabolism. If dopamine is not metabolized, more dopamine, that can treat Parkinsonism. So we have two drugs in this category, MAO inhibitors and COMT inhibitors. Starting with MAO inhibitors first. Now monoamine oxidase enzyme, it is of two types, MAO A and MAO B. You need to remember the important differences between the two. So you can remember easily A for all. MAO A is present at all places. All places means it is present in the brain, it is present in the GIT, it is present in the platelets, it is present in the liver. That means almost everywhere A is present. Whereas B, you can remember, it is mainly present in B for brain. A is present at all places and B is primarily in the brain. Second, MAO A, it is metabolizing all substances. All substances means any substance which contain monoamine in the structure, it can metabolize all. All means it can metabolize endogenous substances like adrenaline, noradrenaline, dopamine. It can metabolize all of them. Not only this, it can metabolize exogenous substances also like pethidine, tyramine, etc. So MAO A can metabolize all the substances. Whereas MAO B, the major substrate is dopamine. Main substrate of MAO B is dopamine. So in Parkinsonism, which MAO will you like to inhibit? A or B? Obviously, we will like to inhibit MAO B because we want to increase dopamine in the brain. So we will want to inhibit the metabolism of dopamine in the brain only. So we will prefer MAO B inhibitors. Okay? So in Parkinsonism, we use selective MAO B inhibitors, and the drugs are selective MAO-B inhibitors. These include salazilin, rasazilin, and a new drug called as safinamide. Salazilin, rasazilin, and safinamide, these are selective MAO-B inhibitors. They are indicated in Parkinsonism. Okay, now a new theory has come that dopamine, when it is metabolized by MAO, it generates some free radicals. One, obviously dopamine will become less because it is metabolized, but second, this metabolism generate free radicals, and these free radicals, they cause neuronal degeneration. So the new theory says that the degeneration of neurons which is occurring in Parkinsonism, it may be because of free radicals and which are produced because of metabolism of dopamine via MAO. So when we inhibit MAO enzyme, MAO-B enzyme, then free radicals will not be produced, so we can stop the neuronal degeneration. So the new theory says that the MAO-B inhibitors, they may possess the disease modifying activity in Parkinsonism. They may decrease neuronal degeneration. Okay, and this drug, new drug safinamide, it is approved for off episodes in on-off phenomenon. So when there is on-off phenomenon, then we can utilize this drug safinamide. Okay, then second group of metabolism inhibitors are COMT inhibitors. And in the COMT inhibitors, earlier we had two drugs which are entacapone. The drug's name will end with capone. Entacapone. Then we had tolcapone. These two drugs were earlier available, but recently we have approved one more drug which is called opicapone. Opicapone is a new drug which is approved in Parkinsonism, and it is approved for off episodes in on-off phenomenon. Opicapone is a new drug. Now regarding entacapone and tolcapone, the basic thing you can remember, tolcapone is not used nowadays, whereas entacapone is preferred. The reason being, tolcapone, the name says it is TO means toxic, to L means liver. Tolcapone is hepatotoxic, so it is not preferred. Entacapone is preferred these days. Okay, so that is about the third group of drugs which increase dopaminergic activity. So we discussed levodopa, we discussed drug releasing dopamine like amantadine, and we discussed the drugs which inhibit metabolism like MAO and COMT inhibitors. Then moving to the last group of drugs which increase dopaminergic activity, and that group will be directly dopamine agonist. That means if we stimulate the dopamine receptors, dopamine is not required, the work will be done. And dopamine agonists can be broadly of two types. One are called ergot derivatives, second are called non-ergot derivatives. So dopamine agonists may be ergot, may be non-ergot. The ergot derivatives include bromocriptine and pergolide. Bromocriptine and pergolide are ergot derivatives, whereas non-ergot derivatives include pramipexole and ropinirole. Pramipexole and ropinirole. The first question is, what is the ergot? Ergot is a fungus. The scientific name is Claviceps purpurea. Claviceps purpurea is the scientific name of ergot fungus. The drugs which are obtained from this fungus are called ergot derivatives, and which are not obtained from this are non-ergot derivatives. The second question is, we have discussed so many drugs earlier, but we never talked about source, from which source they are obtained. But now we are classifying the drugs based on source, whether they are obtained from ergot or not obtained from ergot. So there must be something special. And what is that special thing? The special thing is, all the ergot derivatives have some common properties. And the two important you need to remember, number one, all ergot derivatives can cause vasoconstriction. All ergot derivatives cause vasoconstriction, and vasoconstriction sometimes is so severe that it can lead to gangrene. So ergot derivatives are associated with causation of gangrene. Another ergot derivative you remember, in migraine we use ergotamine, dihydroergotamine. They can also cause peripheral gangrene. Whereas non-ergot derivative do not cause. Second important difference, all ergot derivatives on long-term use can cause fibrosis of various parts of the body, like cardiac fibrosis, pulmonary fibrosis, that can occur on long-term use, whereas non-ergot derivative do not cause this. So because of gangrene risk and because of risk of fibrosis on long-term use, we do not prefer ergot derivatives these days. On the other hand, pramipexole and ropinirole, one thing, they do not cause gangrene and fibrosis, and second, they are very long acting, and because of these properties they have now become the drug of choice for Parkinsonism. Pramipexole and ropinirole are now the drug of choice for Parkinsonism. Not only Parkinsonism, they are also drug of choice for another condition called as restless leg syndrome. These are also drug of choice for restless leg syndrome. Okay, although they are very safe, do not cause major side effects. The main side effect with pramipexole and ropinirole is, one, they cause excessive daytime sleepiness. They can result in excessive daytime sleepiness. And second, they are associated with impulse control disorders. Impulse control disorders, like the person is not able to control himself. Suddenly in impulse the person can do something, like compulsive shopping. The person know that the person do not have enough money to spend, but the person cannot stop himself. In impulse he will shop and waste all the money in that. Pathological gambling, the person will give everything in the gambling. So all these are impulse control disorders associated with non-ergot derivatives like pramipexole and ropinirole. Clear? So these are the important drugs which act by increasing dopaminergic activity. If you remember, which drug can cause Parkinsonism? Yes, antipsychotic drugs. A person has psychosis, person has excessive dopamine in the brain, so we want to decrease that for treatment of psychosis, so we give dopamine antagonist. So we give D2 blockers in that person, D2 blockers दे दिया हमने, and again we become sentimental, हम जज्बाती हो गए, and we give excessive drug. If we give excessive dopamine blocker, what will happen? Dopamine activity will decrease, and when it become less than normal, it will lead to Parkinsonism. So this type of Parkinsonism is called drug-induced Parkinsonism. So what happens in drug-induced Parkinsonism? Receptors are blocked, so dopamine cannot work, so person develops symptoms of Parkinsonism. Now in this drug-induced Parkinsonism, if we try to increase dopaminergic activity for treatment, what will happen? We'll try to see. So when we give levodopa, what will happen? Levodopa will form dopamine, but dopamine cannot work because dopamine receptors are blocked. So levodopa is ineffective. Then we try to give amantadine. Amantadine will release dopamine. Dopamine is released, but it cannot work because the receptors are blocked. So amantadine is also ineffective. If we give MAO or COMT inhibitor, dopamine will not be broken, level will increase, but again dopamine cannot work, so it is also useless. And lastly, dopamine agonist, they cannot bind because receptors are already blocked. So in a nutshell, what we discuss, in a drug-induced Parkinsonism, we cannot treat by increasing dopamine because the receptors are already blocked. So when we cannot increase dopaminergic activity, what we will do? We have to decrease cholinergic activity. So anticholinergic drugs we have to give. So anticholinergic drugs are drug of choice for drug-induced Parkinsonism. Okay. So second group of drugs called anticholinergic drugs. They are drug of choice for drug-induced Parkinsonism. They are drug of choice for drug-induced Parkinsonism. And the drugs are, first we can use central anticholinergic drugs, the anticholinergic drugs which act in the brain mainly. These include benhexol, also called as trihexypheniramine, Phenidine. This is same drug, benzaxole or THP. They are same thing. Then we have benztropine, biperidine, procyclidine. So all these are central anticholinergic drugs. They are drug of choice for drug-induced Parkinsonism. But these are not available everywhere. If these are not available, we can use first generation antihistaminic drugs. First generation antihistaminic drug like promethazine. If you remember, first generation antihistaminic have two special properties. What are those? One, they have very good entry in the brain. They can cross the blood-brain barrier. Entry in the brain is there. And second, they have very strong anticholinergic properties. They have anticholinergic property also. Promethazine has both of them maximum among the first generation antihistaminic drugs. It has maximum entry in the brain and it has maximum anticholinergic property. And if you see in Parkinsonism, we want this only. In Parkinsonism, we want anticholinergic action in the brain, and promethazine has that. So this is a good alternative to benzaxole-like drugs. So if the drug of choice is asked for drug-induced Parkinsonism, answer will be benzaxole. If these are not in the options, then answer can be promethazine also. Clear? So now we quickly revise the important drug of choice in Parkinsonism. Drug of choice for Parkinsonism. If they do not say drug-induced, simply Parkinsonism. Drug of choice for Parkinsonism is pramipexole or ropinirole. But if the question asked is which is most effective drug for Parkinsonism, see the difference. If they ask a drug of choice, it will be pramipexole or ropinirole. But most effective till date is levodopa carbidopa combination. But because of plenty of side effects, we prefer pramipexole nowadays. Most effective is still levodopa carbidopa. If a person cannot be controlled on this pramipexole like drugs, then we have to shift to levodopa carbidopa. But if they ask a drug of choice for drug-induced Parkinsonism, then it will be anticholinergic drugs like benzaxole. Okay, so these are the important points regarding the drugs used in Parkinsonism. Thank you.